monitoring EEG at Lurie Children's and hopefully give you some information and tips that will make this process run smoothly. In clinical neurophysiology, our team of specialists from Lurie Children's Division of Neurology analyzes and monitors the nervous system function to promote effective treatment of neurological diseases and conditions for our pediatric patients. Our specialists, including pediatric neurology physicians and neurodiagnostic technologists, record electrical activity from the brain, spinal cord, and peripheral nerves using a variety of techniques and instruments. In the clinical neurophysiology lab, we perform EEGs, we perform evoked potentials, and there are 3 modalities of evoked potential: brainstem auditory evoked potential, somatosensory evoked potentials, and visual evoked potentials. Our colleagues in the neuromuscular team perform EMGs and nerve conduction studies. We perform about 2,100 EEGs a year at Lurie, and that's what we'll be talking about in this presentation. We have received our 2nd accreditation from ABRIT for 5 years. It's quite an accomplishment. The Lurie EEG program is the first and only pediatric program in the state of Illinois that has earned ABRIT accreditation. Our main hospital is located at 225 East Chicago Avenue. We're on the 3rd floor. We are open Monday through Friday, 7 a.m. to 3:30 p.m. Our phone is 312-227-3010, and our fax is 312-227-9798. And we will put the screen up again at the end of the presentation. We perform routine EEGs at 6 satellite locations throughout the Chicagoland area: New Lenox, Westchester, Arlington Heights, Northbrook, Lake Forest, and Grace Lake. To have an EEG at a satellite location, the patient should be cooperative. They should be 5 years and older or older. We do not do medically complex patients, so no patients on ventilators or with trachs, and no autism diagnosis, although this is a relative restriction. If a child has a diagnosis of autism but is able to cooperate and would let us put the electrodes on their head, then they can certainly have their EEG performed at a satellite location. The reason for these guidelines is that there's only one technologist at a satellite without any nursing support or other tech support that they would normally receive at the main hospital. Families sometimes wonder if satellites are the same, and to put their mind at ease, it's the same technologists that work at the main hospital that would perform the studies at the satellite locations, and the same physician who would be interpreting the data. To order a routine EEG, please call 1-800-KIDS-DOC. We need to have an order fax to be able to perform the study, so diagnosis or reason, faxing that to 312-227-9798. The family may also schedule their appointment using Lurie MyChart. We would still have to have the physician fax us an order. If a sooner appointment is needed, please call the clinical neurophysiology lab directly at 312-227-3010 to help expedite the procedure. To schedule an EEG and first-time neurology visit together, please call 1-800-KIDS-DOC. There are nurses at KidsDoc that will use decision trees to schedule those appointments. And ideally, we would like the EEG to be done prior to the neurology visit. That may expedite the neurology visit if there's urgent results that need to be addressed more quickly. The neurology visit may be moved up. And it also gives the neurologist more information for that first-time neurology visit. Again, we need an EEG order and a separate referral to neurology. So here's the question: why are we doing the test? This is where your input is valuable and would really help us in getting the best possible exam for our patient. Please include any information about the event or behavior in question. For example, if the child stiffens while they are sitting in the high chair, or when they sleep, their leg or arm twitches, all of that information is helpful and will help the technologist tailor the test They may need to add extra electrodes if a limb is moving. There are times when the family is not totally aware of why the test is being performed. So a note on the order would be very helpful and appreciated. This is not an all-inclusive list, but common diagnoses or reasons for doing EEG testing are epilepsy, febrile seizures, staring, abnormal movements, syncope, inattention, brain tumor, stroke, chromosome abnormality, and encephalopathy. For encephalopathy, no sleep deprivation is required. This is a clip of a routine EEG recording just to show you what the brainwaves look like. Our exam time slots are 110 minutes, and of that time, the recording is usually an hour. We have set up time to put the electrodes on, take a little history, explain the procedure to the family. That all happens, and as soon as the electrodes are placed on the head, the recording is started because we want to get all the transitional stages from wake into drowsy into sleep. At the end of the exam, we do remove the electrodes and use water to wash the paste out of the child's hair. The families will still need to wash their hair when they go home with shampoo. This is a picture of one of our EEG machines in our lab. The head box with the electrodes attached is right next to it. This is the head box with the electrodes. Here's the screen that the technologist looks at. And I'm not sure if you can see behind it right here is the photic stimulation lamp, which is placed over the patient's face when photic stimulation is performed. The electrodes are secured to the scalp with conductive paste. So these are the electrodes. The first step is using this prep or cleanser. It's rubbed on the patient's scalp with a Q-tip to reduce the impedance or to remove any excess oil or dirt on the skin so that we get a good connection. We take electrode paste, which is conductive, that is in this tube. A small amount is placed in each electrode, placed on the scalp, and then covered with one of these small gauze squares. When all of the electrodes, 24 on the head and 2 on the chest, are placed, the head electrodes are secured by using this gauze wrap around the head and then tape on top, trying to keep the electrodes secure for the entire recording session. This is a photo of a setup at the head of the bed with the things that I just showed you. So the head box, the electrodes, gauze squares, and the cleanser and the paste. So during that hour of recording, we need to achieve awake, drowsy, and sleep states. We don't want the patient to just be asleep, and that's a common question parents ask. Can we wait to start the test until they go to sleep, or can you wait to put the electrodes on until they're asleep? And we would be losing a lot of very important information if we did not start recording when they were awake and record until they fell asleep. Even if they're moving, we try and minimize the movement because the drowsy state is very important. We do perform activation procedures, trying to record abnormal activity if it exists. We perform hyperventilation if indicated. So for diagnoses of staring or altered awareness, absence seizures, spacing out, blinking, things like that, we would have the child hyperventilate. We also perform photic stimulation, which is flashing the photic lamp over the child's face. There's 10 seconds of stimulation and 10 seconds off. We also ask the family member in the room at that point if they have seizures, because if they have a seizure disorder, we wouldn't want to trigger a seizure in the family member, and we would ask them at that point just to step out of the room. For specific stimuli, if a child has a behavior in question when they are for example, on their laptop, or when they're doing math homework or eating a specific food, we would ask that you let us know that, and the families should bring that along with them. And so while the recording is going on, we would try and recreate that to see if we can record any abnormal activity at the time or actually capture a spell. That would be very helpful. So instructions for EEG. Sleep deprivations are initially given to the families when the appointment is made. Sleep deprivation is very important because it can help bring out abnormalities and increase our likelihood of recording them. It puts stress on the nervous system, and we prefer a sleep-deprived EEG to just the patient falling asleep without any sleep deprivation. The night before the exam, the child should sleep for 4 hours. So from midnight to 4 is what we suggest. We do modify that in instruction for infants, asking the families just to keep their child up for a few hours before the exam, just to do the best that they can. If the child sleeps until they arrive to us, the likelihood of them sleeping with in a strange place with electrodes on their head is really lessened. We do not use sedation because that can affect brain activity. The technologists do make a follow-up confirmation call prior to the exam, closer to the exam, reiterating the importance of sleep deprivation, going over all the instructions again with the family to make sure that everything is clear to them. We have more instructions. The child may eat before the exam and should eat so that they're not hungry and they're able to sleep during the recording. Just no caffeine the day of the exam. All medication should be taken as prescribed. If the child is prescribed rescue meds for prolonged seizures like rectal diastat, nasal Versed, Valtoco, we ask that those be brought with. Sleep deprivation can lower the seizure threshold, and so we would like those rescue medicines available in the lab. If a patient uses BiPAP or CPAP when they sleep at home, that should be brought to the exam because we do want them to sleep, and so we will have that family member attach the BiPAP or CPAP. Their hair should be washed with shampoo only, no conditioner or hair product. The electrodes need to be placed on the scalp, not on the hair, but on the scalp, parted and put on the scalp. And so anything like braids or hair extensions should be taken down if they're going to interfere with us being able to place the 24 electrodes on their scalp. This is a picture of one of our EEG exam rooms. With the bed, we have emergency equipment at the head of the bed. This is the EEG machine again, and the head box. The rooms do not have windows. We try and keep everything cool, dark, and quiet in the lab to foster the idea of going to sleep. Even when the patients walk in, the lab itself has dim lights just to try and keep them calm and in the mind frame of I'm going to come in and take a nap. We follow the COVID protocol for masking of the hospital. There's no eating or drinking by family members in the exam room. We ask that their cell phones are silenced, and audio and video recording in the exam room is prohibited so that we're able to respect the rights and privacy of our patients and of our caregivers. At the time of the exam, we ask one family member to come into the exam room with the patient. If there are other family members, there is a waiting area for them to wait until the exam is completed. We do swaddle our patients when necessary. Sometimes that is helpful in getting electrodes on the patient's head. The parent may be in bed with the patient to help soothe or to help take a nap, to cuddle with the patient. That's helpful. We have iPads, and we've only recently had these in the past few years, and they are a huge help during electrode application. The kids are really engaged in using them and much less worried about someone putting electrodes on their head. We also use that to play lullabies or white noise for relaxation and soothing. And this is also effective even with our older children and teens. Just to have some soothing background noise helps to relax them and facilitate sleep. The technologist and the machine stay in the room for hands-on assistance. Many times we help the family member in the bed with padding or rocking, holding the patient, anything that we can do to help the child fall asleep. We do have a supply of pacifiers, baby bottles, formula, milk, diapers available in the lab in case a family has forgotten or used all of their formula. And following the methods that I just talked about, our clinical neurophysiology lab has a 90% success rate in achieving sleep during that 1 hour of recording. And also, even if the patients did not follow the instruction and were not sleep deprived, 76% of those patients are able to sleep as well. So for results, the EEG recording is read within one business day. If emergent results need to be addressed, the ordering physician is contacted. Otherwise, EEG reports are faxed and mailed within 3 to 4 business days to the ordering physician, and they're also available in the EMR if you have access to the EMR. I'd like to thank you for your attention. Turn that over to either Dr. Stack or Chad.
Oh, okay, that's great. I thought Eric Padilla was going to go. My bad. Let me go ahead and throw up my slide here for you. And folks, if you have any questions at all, either feel free to raise your hand on the hand tool, or go ahead and type up some questions for them so they can go ahead and answer anything that you may have while I go ahead and get my screen set up here. Apologize for the technical delay here.
Very nice, Chris. How quick is it? How quickly are you able to turn around results from the EEG?
It depends. So I usually read all of the EEGs within 1 day. If there is an emergent situation like a baby has infantile spasms, we call those results to the physician who ordered the test immediately, and we make a plan. If the child has an unforeseen seizure in the EEG lab and it needs to be addressed, we will address it by calling the code in the EEG lab, and we will send the child to the emergency room if necessary, and I call the referring practitioner. What we try to do is minimize the level of anxiety of all of our patients. And so sometimes new parents are extremely anxious, and I may call the pediatrician and say, I'm going to give the mom the results because I don't want her to worry all weekend about what's happening with her little baby. So the answer is the turnaround time is very quick for routine EEGs.
Okay. And then Dr. Stack, just to kind of go along with that line, when you do get the results, do you make a recommendation if the patient needs to be seen by needs to continue to be seen by a neurologist?
No, I leave that decision up to the practitioners. And the reason is, while about 2/3 of our patients come from within Children's, about 1/3 don't. And so people are referred to us who have other practitioners. And so I leave that decision up to the referring practitioner, whether it's an APN or a PA or a private pediatrician. We're happy at any point to, consult and refer the patients to Lurie. A lot of people refer the kids for both an EEG and a visit, and that we do the EEG in advance to try to expedite those kids who need to be seen right away. I just checked today just to see what would happen. If little babies, usually babies under a year, need to have an EEG, we can do them within usually a week. And I've had this practice, and so do the women who work with me, of saying, can you come right now? So if you have a baby who is 6 months old and somebody's terrified that they have infantile spasms, we literally say, can you come right now? And understanding most people can't unless they live in the neighborhood, but our urgency is with little babies particularly, but even if you're not a little baby and you need an EEG, we can probably do most EEGs within about 10 days to 2 weeks. Now, the caveat with that in terms of scheduling is at our outreach, we're only there once or twice a month at most of our outreach facilities. So sometimes that is not the case. But of course, you can always be scheduled sooner at the main campus downtown.
Okay, and with that said, now if a pediatrician makes a referral, if they have a patient who's seizing and they say go to the children's emergency room, do those patients that do go seen to the emergency room, do they get triaged quicker for an EEG?
So the answer to that is it depends on what happens in the emergency room. So right now, because of COVID, the hospital is exploded with occupancy. And so there's a lot of kids coming to the emergency room. Many of them during our regular business hours will get a regular EEG from the emergency room, okay, right from the emergency room. And they'll be seen by a neurologist in consultation at the discretion of the emergency room physician who asked us to see the patient. Sometimes it's not an urgent situation, it's more of a chronic situation, and the patient is seen in our emergency room, in which case either the emergency room physician in consultation on the phone with a neurologist or with a neurology fellow will say, maybe we ought to get the child an EEG, and that's expedited from the emergency room. The issue is we need an order from the referring physician, whoever that person is, or whoever the referring PA or whatever is. And so we just need the order. And I've been asked by my front desk ladies to put in a commercial for information on how to contact the families, because sometimes we get an order for an EEG, but we don't have any information that's workable with how to contact the family. So if it's possible, somewhere on the order, if we can have a phone number that we know is workable, it makes our contacting the family to arrange for the visit and the EEG visit much easier. Otherwise, we have to sort of chase around and try to find a workable phone number to contact the family to set this up. It'll make everyone less anxious.